Good afternoon, and on behalf of our Arbovirus study team, we wish you a very heartfelt welcome to this broadcast, which is at the occasion of the closure of a 6-year endeavor, which was called Prepare. Lined up, you see our speakers, who I will introduce one by one during the webinar. Maybe just to give you a bit of a scope on where you are, who is hosting this. This is the Prepare project, funded by the European Commission under the FP7 program. Which was a large network aimed to collaborate with hospitals and primary care centers throughout Europe to develop harmonized large-scale clinical research studies on infectious diseases, to be able to prepare for a rapid response to a severe infectious disease outbreak, as we all have been doing, of course, in the past year, and also to gather real-time evidence for clinical management of patients and for informing public health response. So what you are looking at today is the wrap-up of the work in this large consortium focusing on arboviruses, and you will hear more about the background for that. So with that very brief introduction, without further ado, let me introduce the first first speaker, who is Professor Cornelia Popescu from the Carol Davila University of Medicine and Pharmacy in Bucharest. Cornelia, the floor is yours.
I will tell you about our experience with West Nile virus in Romania. How do you know West Nile virus? Is from flavivirid families, Japanese encephalitis antigenic complex. It is a virus with a transmission cycle between birds and mosquito vectors, but sometimes West Nile incidental affect humans or horses. It is epidemic in Africa, Middle East, and Southwest Asia. It had a sylvatic rural cycle, wild birds, reservoir and amplifying host, and ornithophilic mosquito vectors. Humans are in majority asymptomatic infection, mild respiratory disease, and sometimes in less than 1% of cases with neuroinvasive disease. The first European outbreak of West Nile virus neuroinvasive disease was in Romania in '96 with 393 cases and 17 deaths. It was an urban setting, 73% here in Bucharest, capital center of the country, with an attack rate of 12.4 at 100,000 people, with the highest attack and fatality rates at people with age more than 65 years. Culex pipiens was the vector, and we made in '96 West Nile virus isolation from mosquitoes, Culex species, and from CSF samples, confirmed by virus neutralization with sera from convalescent patients. Post-epidemic sera survey observed widespread subclinical infections per % in Bucharest residents, and uniform seroprevalence rates in all age groups with West Nile newly introduced in immunologically naive population in '96. After 3 years in New York, in the United States, in '99, 59 cases and 7 deaths, with an overall attack rate 6.45 cases per million population. And how do you observe? Here is the same lineage lineage 1 in Romania and New York, similar to strains circulated in Northern Africa, genetic line 1. Slight genetic variation between these two types with increased virulence in the New York strain. How the epidemics evolve after this? In USA, how do you observe? They had cases every year from 1999 until 2017, more than 48,000 of West Nile virus infection with 48% neurological infections, 9% mortality. But in Romania, until 2010, we had only 78 confirmed cases between 97 until 2009. We had from 97 a regional hospital-based surveillance system extended at a national level in 2009. From 2010, we had an outbreak in 2010 with 52 cases. After this, between 10 and 30 cases, and in 2016, 93 cases, 66 in 2017, and 276 in 2018. See, this is three peak of the outbreaks in Romania after 2010. And we observed that, sure, it was a reemergence of West Nile virus in Romania from 2016 until 2019. If we discuss about 2020, we had only COVID-19. We had only one case of West Nile virus, one case of encephalitis with West Nile virus in our hospital, also infected with COVID-19 after the admission in other hospital, admission for encephalitis, and after this infected with SARS-CoV-2 and moved in our hospital. What is important in new emergence of West Nile virus in Romania? When we discuss about the mortality, we observed high mortality in 2016 and 2017, around 20%. We observe also this high percent in Israel, in Italy, in Greece, especially in Greece and in Serbia. Not so much like in USA, and not so much like in Romania in 96, when we had only 4.5 mortality rate. Even if in 96 we had only lineage 1, after this in 2010 and 2015 and 16 we had other types of lineage 2, and different strain, initially with Volgograd strain from Russia, and after this especially Nea Santa strain from Greece 2010, who had co-circulation in Romania, and the replacement of lineage 1 precedent one. Yes, here in we have a phylogenetic tree of West Nile lineage 2 in Romania 2016, 7 and 15 and 16 from Central Southern European clade here, from Danube Delta, and here from Bucharest. But course circulation with Volgograd 2007 like strain until 2016, and the replacement from 2016 of this strain. We observe this re-emergence not only in Romania, also in Europe, and housing it all in our surveillance. Reported in 2018 an early detection massive increase in the number of the cases, with 2083 cases higher than normal, the total number of 1,800 from the previous 7 years. In Mermaid's Arbo, our contribution was 191 screened patients, 121 enrolled, and how do you observe? Only one case in 2016 when we start. But after this, around 40 patients every year. And we observe in our patient with West Nile virus, we have analysis of 93 patients with West Nile virus neuroinvasive disease, 30% encephalitis and 70% meningoencephalitis, with 24.7% death, 23 deaths, 21 during hospitalization, and 2 deaths first month after this discharge. And the predictors for unfavorable evolution was age, ischemic heart disease, coma, obtundation, change of consciousness, speech disorders, and confusion. This was the most important factors related with the death. Also, we observed changes in duration from onset to hospitalization, and in hospitalization length in the patient with age more than 75 years. And now we try, but COVID-19 broke our plans, but we hope in the future to monitor these patients because in the literature we are already reported morbidity up to 8 years post-infection with chronic neurological diseases, neurocognitive impairment, depression, fatigue, persistent neuromuscular paralysis, and tremors in 40% of symptomatic West Nile virus infections and 80% of those who initially present with encephalitis. This is observed in MRI, and we hope in the future to cover this disease not only in the acute phase and also in the follow-up of these patients. In the conclusions, West Nile virus neuroinvasive disease is an emerging disease in Romania with an important associated mortality related with age and also with cardiovascular comorbidities, and probably with the new strains spread in our country. And how do you observe? Several neurological signs are predictive for unfavorable evolution. Thank you, and thank you for our collaborators from Mermaids Arbo. Here we was in I think in March 2018 in Bucharest in Arbovirus workshop in the Prepare consortium and ESCMID related in snowy days in Romania, even if it was March. And thank you for Luis and James, Marion, and other collaborators from Mermaids Arbo.
Thank you very much, Corneliu, for a great update, making very clear why it is important that we pay attention to these viruses from first-hand experience, and also illustrating the disease severity, and also that there are viral factors to consider and host factors to consider, which is at the core of what we're trying to do through the Prepare activities. And I'm sure we can have some discussion on those observations in our panel discussion later.
Sure.
Yes. With that, let me switch to the second presenter. So just to clarify, we will have 4 consecutive talks and then a panel discussion where we can address all your questions and maybe have some debate about the future of preparedness. So be sure to, if you have questions, to ask them in the questions button that you can see on your screen. With that, let me introduce the second speaker, Dr. Louise Siegfried, who is a clinical research fellow at the Center for Tropical Medicine and Global Health in Oxford, University of Oxford, and who really, I could say, has been one of the key, the spider in the web of the mermaids studies, and really a crucial role in trying to move the studies forward, liaising with all the sites, liaising with the investigators in the different countries. And she will give an overview of the work that has been done through the Mermaids project on arboviruses.
Okay, thank you, Marion, for the introduction, and thank you, Cornelia, for an excellent presentation. So I'm going to present briefly about the preliminary data from the Prepare Mermaids Arbovirus study, which has been running, as Marion said, for the last 5 years in across sites in Europe. So I'm Louise Siegfried, for those who just joined the meeting. I'm Louise Siegfried, I'm a clinical research fellow working with Prepare and ISRIC at the Center for Tropical Medicine and Global Health at Oxford University. So I've got the honor to present the Mermaids Arbovirus study. I want to highlight that this is very much a collaboration, and that has been, it hadn't been possible if it hadn't been for all the site investigators across the sites taking part, such as Dr. Cornelia Popesco, and also to all the patients taking part in the study. So the Arbovirus study, Arboviruses stands for arthropod-borne viruses transmitted by vectors in Europe, predominantly by mosquitoes, ticks, and sandflies. It's a seasonal, the Arbovirus study is a seasonal prospective observational study. It was open from May 2016, and the last patient was included into the study at the end of October 2019. It includes a follow-up post-discharge, so the final patient was followed up in January 2020. So the study completed just before the COVID pandemic really hit Europe. So it's set in 21 hospital sites in 7 countries across Southeastern Europe. The main aim was to study the burden of endemic arbovirus infections in the region by including adults admitted with symptoms that could be compatible of a suspected arbovirus infection. It was also set up with a syndromic design so that it would be prepared to be able to include patients presenting with any new or re-emerging arbovirus infections of public health importance and epidemic potential. So included, for example, travel-imported new emerging arboviruses. The primary objective is to estimate the proportion of adult hospital admissions with a febrile illness in the southeastern Europe that are attributable to 4 of the endemic arboviruses infections of clinical significance in the region. So this includes West Nile virus, which Cornelia presented on. So West Nile virus is predominantly transmitted to humans by mosquitoes and mainly asymptomatics, but can in some proportion of cases present with a West Nile virus fever, or in some cases with encephalitis with a considerable mortality risk. Toscana virus is endemic around the Mediterranean region. It's predominantly transmitted by sandflies, and again, most cases are thought to be asymptomatic, but can present, some people are affected with symptoms of meningoencephalitis, which might require hospitalization. Tick-borne encephalitis virus is transmitted predominantly to humans by certain different types of Ixodes ticks. And it can also, so often it can present with just a flu-like illness, but in some people, as the name suggests, can present with encephalitis and can also lead to prolonged recovery rates and chronic sequelae in a subset of people. And then Crimean, the 4th virus is the main focus of the studies, Crimean Congo hemorrhagic fever virus, which is also endemic in some regions in the southeast region of Europe. It's, as the name suggests, can cause hemorrhagic fever, and in untreated cases and even with treatment can have a significant mortality rate. So that was just a brief overview of the viruses that we focused on and the primary objectives. The secondary objectives also to look at treatment, clinical management and outcomes of the viruses by region, and analyze severity of disease in relation to demographics, and to characterize antibody levels up to day 60 post-discharge. And we also are going to analyze health outcomes, physical and psychosocial and functional health outcomes, and burden of disease in relation to severity and demographics. So coming back slightly to the development of the study and the reason that we included these viruses and the regions. So we did a literature review and looked at surveillance reporting, and this map shows where the surveillance data and from evidence reviews there have been reports of cases or seroprevalence of the viruses. So the red color shows where we found documentation of seroprevalence or cases of criminal hemorrhagic fever. The yellow one shows the tick-borne encephalitis virus. The green map shows where we found reports about cases, sporadic cases or seroprevalence of Toscana virus, which is the one that there's less data on in the region. And the blue one shows where the reports about presence of West Nile viruses. And there was also, looking at surveillance data, indications of potential gaps in surveillance reporting and notifications. So looking at this, so the study was set up, focused on the Southeast Europe. If we could, we would have focused on the whole of Europe, but we're also constrained with about poor resources. So this was considered the area to the most importance, and also of a higher risk of introduction of new emerging arboviruses. So the inclusion criteria into the Mermaids Harbour study was adults 18 years or over. They were admitted to hospital with onset of symptoms of either suspected encephalitis or meningitis, or both meningoencephalitis, or a rapid onset of fever measured at 38 degrees or self-reported, and at least one of the signs or symptoms in the list presented on the slide within 21 days of onset. So fever together with neurological symptom, severe headache, myalgia, arthralgia, rash, hemorrhagic symptoms, and/or thrombocytopenia. So this table shows the study procedures, just a brief overview. So we collect the data on admission, and also during the admission, data on clinical observation, medications, and management. In addition, we collect the research samples, blood, serum, and urine on admission and at discharge, and at day 28 follow-up post-discharge, we collect the serum and urine, and again a serum sample at day 60 post-discharge. We collected the CSF samples, cerebrospinal fluid samples, if the patient had had a lumbar puncture as part of routine clinical care. So in addition, we measured health outcomes by using a validated Eurocall EQ5D5L tool and the Liverpool outcome scores for adults. We measured this at discharge and in the 2 follow-up appointments. So all the samples taken for research were batch shipped at the end of the season to our reference laboratories. So for serology at the Erasmus Medical Center in the Netherlands, and for RT-PCR at Charité Berlin in Germany, and a serum sample is also stored in a biobank at Antwerp University in Belgium. This map shows the countries, sites and countries that took part in the studies. And there was a fantastic effort. They managed to include, but through a fantastic effort, managed to include 921 patients. About a third was included from Albania, and a third in Romania, and then followed by inclusions in Bosnia, Herzegovina, Croatia, Greece, Kosovo, and Serbia. So I'm going to present some preliminary descriptive data. So due to the COVID pandemic, despite the COVID pandemic, we've done a fantastic effort of analyzing all the samples, which Edwin De Bruyn will talk more about the reference diagnostics and the complexity around the diagnostics in the presentation afterwards. And I'm going to present some preliminary descriptive data coming out of the study. So looking at the inclusion symptoms on inclusion, most patients had symptoms of suspected encephalitis or meningitis, followed by fever, myalgia, arthralgia, and severe headache. and a low proportion presented with rash, thrombocytopenia, and hemorrhagic symptoms. Looking at the overall cohort, the median age was 43 years and 58% were men. 56%, so more than half, had no comorbidity, previous comorbidity. About one in four, a quarter, had chronic cardiovascular disease, and about 1 in 10 chronic metabolic disease, predominantly diabetes. So for the reference diagnostics results, looking at the confirmed and probable cases when we're combining the PCR and serology, which Evan de Bruin has mentioned, we mention more in detail in the next presentation. 5 to 6 of the patients had confirmed or probable West Nile virus infection detected, 1.6% tick-borne encephalitis virus, 1.7% Toscana virus, and 0.5% had a few cases of detected on Crimea Congo hemorrhagic fever virus. So of the confirmed or probable cases, when we're looking at the distribution across the regions, we can see here the turquoise-colored bar or bluey-green bar represents Romania, where most of the West Nile virus cases included in this study were detected, but we can also see that there was West Nile virus cases detected across the region. Tick-borne encephalitis virus, again, the highest proportion was detected in Romania, and but also cases in Croatia and Serbia. For Toscana virus, we can see there's cases detected across the countries taking part, across the sites taking part. And Crimea Congo hemorrhagic fever, most of the cases were picked up in the cohort in Albania and also in Kosovo. So we also did, from the reference diagnostics, looking at the confirmed, this bar shows the proportion of patients that had confirmed and probable, also possible cases, and also where the antibodies results indicate prior exposure. So we can see that quite a high proportion of about 30, just over 35% indicated that I have a previous exposure to Toscana virus, and also quite a high background rate of potential background rate of tick-borne encephalitis virus and West Nile virus. So this table shows some preliminary descriptive data on the patients that we detected with a confirmed or probable one of the arboviruses included. And looking at the age range here, we can see that for Toscana virus, for example, even though it's a low case number, we can see that it is affecting younger adults as well as older adults. And this, when it comes to Toscana virus, it has also been documented in previous literature. So, and also looking at the comorbidity, quite a high proportion didn't have any pre-existing comorbidities, indicate that previously healthy adults at any age can be at risk of severe arbovirus infection requiring hospitalization. We asked patients if they had recollections of previous insect or parasite bite. As we can see here, tick bites, only 53% of the confirmed or probable tick-borne encephalitis viruses had recollection of previous tick bites, and none of the case of Crimea Congo hemorrhagic fever viruses, showing how recollection of tick bite is not a strong indication. Syndromes of inclusion in the arbovirus cohort, we can see a high proportion of cases presented with suspected CNS infections, especially for West Nile virus and tick-borne encephalitis virus, and also for Crimea Congo hemorrhagic fever virus. In this cohort, we also see a high proportion with hemorrhagic or thrombocytopenic symptoms. This is very preliminary data on the clinical management. The blue bars represent the proportion that were administered antibiotics on admission, and the red bar antivirals. The green bar shows corticosteroids, and the purple bar those administered immunotherapies or blood products. So we can see that quite a high proportion of patients were administered antibiotics, and about for tick-borne encephalitis and West Nile virus, about half were administered antivirals, and for CCHFV we can see a higher proportion administered antivirals, corticosteroids, and also immunotherapies and blood products. So looking at the outcomes of the arbovirus cohorts and also the total arbovirus cohorts and the total cohort, the median length of stays for the arbovirus cohorts range from 11 to 13 days, so quite a long admission time. And the in-hospital mortality rates was 5.8% for the West Nile virus cohort, and there was no fatalities for the other arboviruses. And in the overall cohort, 89% of the inclusions were documented as having an infectious disease and outcome, but less than about a third had a pathogen a causative pathogen documented in the documented. So this is a preliminary data. So the analysis is still ongoing, and we aim to present it for wider dissemination, the full analysis shortly. By looking at it, we can see that arboviruses and other infectious diseases and CNS infections continues to be a burden on population health and health systems in Europe. Arboviruses pose a risk of severe disease, including CNS infections with long admissions rate, and is affecting previously healthy adults at any age. There's no recognized treatment, and there's limited access to vaccines. There's a vaccine against tick-borne encephalitis viruses, but it's on a targeted approach. And the study also shows that using a syndromic multi-site study design, being active and ready to respond, it also enables inclusion of other travel-imported arboviruses, such as Zika viruses and chikungunya viruses. So while the study was up and running, we also the study setup was delayed by the Ebola outbreak, and people involved responding to supporting the response to Ebola virus outbreak. And during the study, we had the Zika virus outbreak in South America, and we can see that the syndromic study design managed to include Zika virus cases presenting in the region. I think it's clear there's a need for research into treatments and prevention to reduce the burden on health and health systems from arboviruses and other CNS infections. And by preparedness, we need strengthening preparedness, early identification, diagnostics, and having pre-established active studies and networks are key for early detection and timely response. So before I finish, as I mentioned in the beginning, this is very much a collaborative project, and behind the scenes, we like to is all these all our fantastic site investigators across the regions who've done a fantastic work, and has been amazing to collaborate with, and we hope that we will continue our collaborations going forward. So thank you very much.
Thank you very much, Louisa, for a great overview of a huge amount of work, as you say, by a huge amount of people. These things look simple on paper, in the one-page descriptions, but it is really a huge effort. And thank you for that. So we will move on to the next presenter, who is Erwin de Bruin. Erwin is a senior research technician at the Erasmus Medical Center, who has spent many years in his career developing innovative serological multiple infections in one go, as part of the development of tools for preparedness. And he will explain some of that work. So what the diagnostic, how they came about. Erwin, go ahead.
Okay, so I will tell something about the diagnostic result of the arboviral clinical studies done in the PREPARE Mermaid study. And I will tell something about the critical steps, especially for serology. So the diagnostics assays used is the molecular diagnostics, which was done in Berlin on EDTA blood, and serology was done in Rotterdam. TBEV, Western and Toscana virus were tested by protein microarray, and then if when positive, the results were confirmed by virus neutralization. CCHF was also tested, but with using commercial tests. First, all samples were screened by an ELISA, and when positive, samples were confirmed by an immunofluorescence assay, also commercially available. So, but to interpret the result of the diagnostics done, you really have to understand the kinetics of after arboviral infection, and also for the humoral responses. So after an infection, this is an example of the arboviral infection and the kinetics after that. So if you have a primary infection, then you have a start of symptom onset, which is called day 0. Before that, viral might already be detected in a serum and afterwards as well, but it might be very short, especially for arboviruses. And in day 4 to day 5, you will the IgM will come up and will rise until day 20, and after that, it will start waning. It might take short, but also longer, especially for example for West Nile virus. This might take a couple of months. And after day 7 or day 10, days post onset, you will see the IgG going up, and it will also rise for 2 to 3 weeks, and then it starts waning again also. And this will take a long time, in most cases. And it will be present for a long period of time. And if there is a secondary infection, the picture will be a little bit different. Then at the day 0, you can expect from day 0 to day 7 that IgG comes up very quick, and most of the time also reaches high levels within 2 to 3 weeks. There might be IgM present as well, but it's not always the case. And viral presence is more or less the same compared to the other one, although IgG will come in very quick. So keeping this in mind, we started interpreting all the samples, and critical steps for the interpretation are the timing of the samples versus the onset of symptoms. Also the completeness of samples, how many samples did we get, and what was the timing of the sample, and what type of sample. This is mainly important for molecular methods. For example, West Nile has a very short period being detectable in serum, but for urine you see a longer period of time that it is detectable. But then you also depend on the clinics. If they collect only serum and not urine, this might be not detected by molecular, then the virus might not be detected by molecular methods. Another thing which is very important is the assays used regarding specificity and sensitivity. We use this testing algorithm for the test. We received all the samples at once for the complete year, so we started testing the day 28 samples. If there was no IgM or no IgG present on day 28, then it was regarded negative. If you did see any IgG on day 28, we also tested an early sample, the day 0, for IgG and IgM. And if you did see a seroconversion or even a 4-fold increase on IgM or IgG, then the test was also tested by a secondary conformational test. And if both were positive, then we regarded the sample confirmed positive for that specific virus. There was no seroconversion. Then we looked at what is happening, if there is any titer change, or is it stable in time, for example, the IgG, then it's probably an old infection. And if that could be confirmed by a secondary test, if virus neutralization, it was confirmed old infection. But if you want to use this algorithm, you have to be sure that you know exactly which timing of sampling was done. And here you see an example. Here you see when the samples for this study were collected. So in the blue line represents day 0, and the straight vertical line, and the other blue line represents the real timing of the day 0 sample that we received. And the same for the orange line, which is the day 7 sample, the vertical line, and then the the other orange line representing the real timing of the day 7 sample we received. And that also for day 28 and the day 60 sample. I have to stress that this is not because the sampling was done wrong, but this is more the reality of what you get from a clinical site when they collect samples. And it's very hard to really get a day 0 or a real day 7 sample. That's not always the case, and sometimes you just, this is what you have to deal with. But if you then look at the timing, then you see that if you want to have a real early sample before day 7, you see that day 0 is collected in the meantime around day 5. So most of the day 0 samples, some of the day 0 samples are already later than day 7, meaning that it's difficult to get a real early sample, which is very important to see the kinetics of your immune response. So if you further, so to interpret the result, we stratified the different sample collections for each patient into different categories. So the blue bar on top here, you can see that that's the first serum sample collected within the first 7 days post-onset. And if there is a second sample in the green bar, so after day 14, we call it an optimal sampling. If you only receive 2 samples, but within the first 14 days, we call it a medium early sampling. And if you received 2 samples, but both after day 7, we call it a medium late sampling. If we received just one sample, but within the first 7 days, we call it suboptimal early. And 1 sample after 7 days, we call it a suboptimal late sample. If you then look at the full study, we see that around 40% was collected in the good collection sampling, meaning that we have 1 sample from day 0 to day 7 and 1 sample after day 40. If you then put everything together in a decision table, so on top you see the sampling timing again, from good, medium, and bad, and also when you don't know the timing of the sample, so the day post-onset is not given, and we don't know exactly when the samples were taken. And on, let's say, the y-axis, you see the different outcomes that you can have for serology. So on top you see the seroconversion, and below you see no IgM or IgG detected. In between you have some more inconclusive, more doubtful results that you can have. And you can see that if you have an incomplete sampling, suboptimal sampling, you see that most of the time you have a less conclusive result. If we then have a look at all the results for all the target viruses done for mermaid, Arbomermaid, in total we did 3,359 determinations for all patients. So this is a real big table of all the years and all the target viruses and all the results we have. I will not go into it for each detail, but I just want to take out some of the results, the remarkable things we saw. One of the things is that West Nile viruses, as Corneliu already told, that there was an epidemic during the sampling years that we also included in the study. And that was also reflected in a number of cases that we detected for West Nile, especially within 2017 and 2018, we have quite a high number of positives. Another remarkable thing is that for Toscani virus, we had a lot of exposed prior exposure measurements, meaning that we saw an IgG which was stable in time, so not the current infection, but it's a probable historical infection. And you can see that this accounts also for all the years. Another thing that stand out here was the fact that for TB-EV we saw quite a higher exposed number of exposed people in 2017, 2008, which was not reflected in the number of cases. This might be vaccination, but well, we don't know for sure that. If you then look at the serological results for West Nile virus and then all the countries, then you see that the highest incidence was measured within Romania, but also Bosnia, Greece, and Serbia showed quite a high number of cases. And what you also see is that different when compared, for example, to Toscana virus, that the number of exposed people within the population, so the population background, stays low within this study for West Nile virus. For Toscana virus, you do see a high background, as said before. And if you look at the different countries, you see that this is mainly within Albania, reaching almost 50%, which is really high, also compared to the other countries. So coming to some conclusions. So the ideal sampling for serological diagnostics is challenging, and the use of an interpretation or decision table is important for population study. There's an ongoing outbreak of West Nile virus in Southeast Europe, and there's a high background of seroprevalence of Toscana virus overall, especially within Albania. And within this study, we have only little evidence for hospitalizations for TB-EV, but also for Crimean Congo. And then my last slide, I have to acknowledge all the other people that also worked on this. Of course, at the Erasmus, a lot of people that helped with the diagnostics. In Berlin, they did RT-PCR. Biobanking was done in Antwerp. And in Oxford, they collected all the data, the clinical data, and of course, all the clinical sites that helped collecting samples and included patients.
Thank you very much, Erwin. Cornelio, over to you.
Yes, very nice presentation, and we'll see the results of the study that confirm our supposition about the viruses from Romania. We don't see Crimean Congo hemorrhagic fever, even if we have serological evidence in animals in eastern part of Romania, in Dobrogea region and the Danube Delta, this area. We didn't have till now cases in humans. We'll see.
We'll see.
Yes, I don't know if probably it is in work. If you had any sequencing of the viruses isolated, if you have some isolation of the viruses and sequencing in West Nile, Toscana, to see which lineage. About West Nile we know, but about Toscana and tick-borne encephalitis we don't know. We don't have so many data from Romania.
Yeah, so we have to look at the PCR results. So for West Nile, there certainly is sequencing data that were not presented, and of course they are reflective of well, what you have already shown. But yes, that needs to be shared. And I don't think there were any PCR positives for that sequenceable positives for the other viruses. So, but maybe let's go and do the final presentation first, and then go into the discussion. Yeah. Okay.
Yes. Okay, Marion, the floor is yours.
Yes. The final talk is looking at, so as you do at the end of a project, but what lies ahead. So what else can we expect? And I've been asked to also highlight some of the other projects that are ongoing in this space. So this is, so Prepare Arbo made the choice to focus on a specific range of countries where there was evidence for the 4 target viruses that have been studied, and where looking at the European CDC maps, there also was a surveillance gap. But the question is, what are the projections for the future for Europe and for the different regions in Europe? I'm sorry about that. And can some of the emergence of arboviruses be forecasted? And that's the bridge to another European project that's ongoing. And the reason, the background for that comes from observations in other arboviruses. This is an example from Zika, a paper from the Genomics Initiative led by Nuno Faria, that has looked at the viral genomes of Zika virus infected patients that were diagnosed across the Americas. And if you recall that public health emergency was declared around here, but from the viral genomics, it was clear that the introduction, the incursion of the virus into the continent already dated well over a year before, if not longer. And so that meant that the circulation of this virus that causes such severe complicated birth defects had gone under the radar for quite a long time. And that's, of course, the challenge in when thinking about arbovirus preparedness. And we do have warning signs. We know, of course, that there is endemic presence of Westnile in certain parts of Europe, but there's also other alerts, outbreaks of viruses that are introduced, like chikungunya, dengue virus, the examples of the past few years, that tell us that the potential for introduction and expansion of these arboviruses is there. And so is the knowledge from the entomology field that has looked at the presence of different types of vectors, mosquito vectors that can transmit these viruses in different parts of Europe, and particularly, of course, also the invasive species that are a concern, but that's not necessarily, that's not an essential factor. So in thinking ahead, some key questions are: what drives arbovirus epidemiology? And it is really, well, simply said, a convergence of ecological and climate factors that need to be right. You need vectors, the different type of mosquitoes that can be infected and can amplify the different arboviruses, but also can transmit these to hosts. And of course, you need different hosts. You need to have, of course, the people present in enough densities for an arboviral outbreak to become visible and clinically. And there's a whole range of factors that impact on any of these above, like climate change, change in land use. We see successive epidemics, think for instance in the Americas, Zika on top of dengue, which gives different types of interactions and new pathology. And of course, all of this can be influenced by large changes in density of people or vectors or hosts. And the question is, can we be better prepared given all of this? So that thinking is what is part of, what is at the core of a sister project to Prepare, which is called VIO, which stands for Versatile Emerging Infectious Disease Observatory. And in this project, the ambition is to try and use knowledge from ecology, from host movements, and about, of course, people's behaviors and presence, to see if that can be turned into a prediction, outbreak risk prediction program. Now let's look at some of that. So one of the, this is again looking at sort of projections of where different arboviruses have been detected in Europe from a very nice review by Luisa Barzon from the University of Padua. And there's this big yellow figure that reflects Usutu virus, a flavivirus that has creeped up across Europe in the past years. And if you compare Usutu versus West Nile, we think there's things to learn there. They may be transmitted by the same vectors. The hosts in which these viruses are brought in and can be amplified are overlapping. The habitats in which this happens are overlapping. But the viruses have, when they infect people, very different outcomes with Usutu virus infections mostly inapparent, although neurological complications have been observed. And of course, West Nile, we've heard, is the more severe part of the family. And of course, these viruses have a very different geographic region. So can we somehow learn to predict what could happen with West Nile from the Usutu virus studies? Now, one of the foundational studies has been this work, and it's published, and it is trying to say, okay, let's put some thinking into what factors could be used to predict arbovirus emergence. And that is looking at the literature and the data that say what does habitat suitability mean? What does climate suitability mean? What temperatures and what duration of night temperatures, for instance, is important to allow for arbovirus replication in mosquitoes? Many different factors that were built into this joint risk analysis tool. And then the tool was developed to try and say, what if you look at risk of introduction for 6 arboviruses, what would be the best places to look for them? And then the same question, but now looking at where would you look if you look for establishment of these different arboviruses? And that's an approach trying to see, instead of random surveillance all over a country or a wider region, can this be somewhat targeted to hotspots, to higher risk regions? So this is what that then looks like, is that there has been an effort for a couple of years now to try and sample birds, live birds and dead birds, but also mosquitoes, for the presence of arboviruses. And this is results from some of that work by Emmanuel Munger from Erasmus, who has looked at the presence of Usutu virus in this wild bird surveillance and also in the dead bird surveillance, and has observed spikes of Usutu virus presence in different years. She's also looked at the genetic sequence of those viruses, and through 3 years, 2016, 17, and 18, and you can see that there's differences. There are different lineages that co-circulate, but the bottom ones here are not consistently present, but the top ones here, the Africa lineages, are present in all the years and seem to cluster together. Now, if you add in a timed phylogenetic tree similar to the one that I showed for the Zika virus, you can actually see that we're looking at a similar situation where the phylogeny dates back to quite some time ago. This is here shown for the Europe 3 lineage. You can see that there have been expansions, but you also can see that there's extinction of many of these lineages. So this picture looks like repeated introductions maybe, or small pockets of virus present. That pattern is different if you look at the Africa 3 phylogeny. First of all, you see that dates back to a more recent date. Again, an expansion, but continued presence of all these different branches. So that is more, that seems more like an enzootic presence. And it is important to, I'm sorry, I need to play with my, yeah, to stress that this preceded by several years the time when the presence of this virus was noticed through bird mortality and testing for Usutu and then again somewhat later also detection of Usutu in some blood donors. So that is a clear example of how ecological, so risk-based ecological surveillance can actually help detect circulation of arboviruses. Now, by that same approach, just very recently, in 2020, the first cases of West Nile were detected in the same region, so not exactly a place where we would have expected it, although given the history now with Usutu virus, maybe it is. So West Nile virus detected in a couple of different wild birds, and in the mosquitoes that were also sampled, and in some sentinel backyard chicken. And following that, and following the alert around that, the first human cases were detected in our country as well. And then, of course, it's important to look at what are these viruses, what do they look like, and they do cluster with viruses as they have been seen in other parts of Europe. And of course, it is important to try and understand how these viruses move around the continent. So this is what that does to the West Nile map of Europe. So Cornelio, I think we have to work on these region notifications also, but where we now have the known regions where particularly clinicians also are familiar with the presence of these arboviruses, but also these pockets now in other parts of Europe that need to become aware of these infections. Now, some of the tools that are developing is maybe to also start engaging citizens more in surveillance, proactive surveillance. And here is work also going on in the sister project in VIO, and that is trying to use citizens' cell phones to help collect data on mosquito activity, biting behavior, and also mosquito types. And just over the past year, what was developed is image recognition patterns trained by a network of entomologists and machine learning, and that now can accurately say whether the mosquito on the picture is one of these different species. And the next year, this will be deployed to see what we can do with that for mosquito surveillance. For instance, if you look at this invasive species, can citizens then maybe start to help feed the surveillance? This is what a display like that looks like. So those are just some closing remarks. So there is a diverse presence of arboviruses in Europe. Geographic ranges overlap. The diseases associated range from mild to severe. And ecological surveillance suggests that there may be more present in other parts of Europe than we might be thinking. So clinical and diagnostic preparedness are key. And with that, also novel tools for prediction and early warning are needed. So with that, let me stop sharing my screen. Yes. And we can go back to the panel and see what if we can have some discussion on this. Okay, so maybe just to get started, let's start with maybe initial questions talk by talk. So Corneliu, so you've shown the pattern of essentially detections of West Nile cases in your country. And one of the questions that has been asked, do you have an explanation for the rise in 2018?
Can be more factors. We don't know exactly, but the climate is one of these, because it was warmer in these years. Also the change of the strains, and also the replacing of the strains. Sometimes part of them co-circulating, and maybe reassortance between the viruses. I don't know exactly. And for us is not so, and completely change of the lineage, because we had lineage 1 for 15 years, and after this lineage 2. And it's possible that we don't have so much cross-reactivity between immunity after lineage 1 and lineage 2 contact of the humans. But also for us was very important the high rate of the mortality. And the reason, probably the first reason, is the circulating strain with more virulence and more increase in the rate of the mortality, aggressivity of the virus.
So maybe to follow up, one of the questions that I hear a lot if what we think about and talk about arbovirus preparedness is that somewhat cynical remark saying, well, what would you do? Because that's unstoppable, and we have no treatment, so we will deal with it when it comes. I mean, I'm saying it a little bit cynical here. Now, I noticed that from Louise's talk that there is actually quite a bit of antiviral treatment mentioned. So is there any work ongoing in that arena that we should think about building into a future phase of the clinical research preparedness?
I don't know, Luis, if has some plans about this. We don't have in Romania any clinical study in this moment about treatment of the West Nile virus encephalitis or something like this.
So, Louisa, have you looked into I know the data analytics is really starting as we speak, but I was struck by that high number of antiviral treatments. Have you looked into the type of treatments?
So we started with preliminary data and we start looking into it. So a lot of people have had from the preliminary data, a lot of people were entered as suspected encephalitis or meningitis or suspected encephalitis mainly, or some meningoencephalitis on the inclusion. And I mean, that could potentially explain why there was a high antibiotic usage and antiviral uses, I think predominantly acyclovir, before there is access to a diagnosis. So I think the early diagnostics is one key to monitor the treatments, but then in terms of reducing antibiotic usage and the correct antiviral usage. But also, I think from our previous studies, they're very limited. There's only some case series looking at treatments for West Nile virus in the US, for example. We didn't find any large studies, and I think there is a gap in kind of a proper RCT on treatment.
It's difficult to have large studies because we don't have so many cases, maybe some thousands per year in good years for West Nile virus, but only this in all Europe, not only in Romania. If we have more than 100, 200 cases, it is an important season.
That's of course a key argument for having a clinical network.
Yes.
And the multi-sites,
yeah.
Multiple sites, globally.
Yes, and one other observation that struck me was the immunotherapy that was apparently mentioned several times.
The immunotherapies and blood products was mainly, again, we haven't looked at the details of that, but they were mainly seen for patients with Crimea Congo hemorrhagic fever viruses. So we haven't looked into detail exactly what was administered yet.
Okay.
Yes, in Romania we use acyclovir for the start. We have in 1-2 days the results from the CSF and from the blood for the IgM antibodies. Not so rapid the PCR results, but the IgM antibodies in 2 days. We have the results and stop the acyclovir. And we use in Romania corticosteroids in encephalitis, viral encephalitis, especially in severe cases.
Mm-hmm.
And I don't know, I know that in Western Europe, they don't use so much corticosteroids. But in Romania and I think in Eastern Europe, we use corticosteroids, not in high dose, Also, we used corticoids from the start in COVID-19 patients with severe disease. Until the other studies or these, we used corticosteroids in patients from ICU or near ICU.
Well, yeah, I think the pandemic is a good example of why you would also want to trial those types of treatments. It's not just the targeted antivirals, but just any treatment algorithm that can help outcome, can help improve outcome. So I think it's really interesting data to work with for the future. I see a question for Louisa. Can you tell us from which part of Romania patients with positive TBV antibodies were? And because the vector-borne diseases are not uniformly distributed in Romania. Not sure if you can do that from the top of your head right here, but that's a question.
I don't know whether Erwin, has the data on which sites in Romania.
So far, I only know whether it's in Romania or another country, not a place within the country. That I don't know.
I think it is interesting for me too, because in Bucharest, we don't have tick-borne encephalitis. It is possible, I don't think, but I think that we had a patient returned from Switzerland and introduced in the study with tick-borne encephalitis. And it's possible one of these, but the others, I don't know if we have. We had some few cases of Toscana virus in 2017, 2018 in Bucharest. and it's possible from the patient, from the mermaids, Arbo, to be some of them with Toscana virus from Bucharest. But about tick-borne encephalitis, probably the positive results we'll see, but I think it's from Cluj, Sibiu, or Timișoara, in the western, northeastern, eastern part of Romania.
Yeah, and for the tick-borne encephalitis, there was a travel from Austria and Switzerland. A reported travel from other parts of Europe.
Okay.
So that's
yeah. So interesting question from the audience. I think for all of you, all of us, how has the COVID pandemic interrupted your work to date? Has it been impacted negatively? And do you have any recommendations, lessons learned going forward? Let's start with the first one. Has it been impacted?
Can you repeat the question? Because
how has the COVID pandemic interrupted your work to date?
A lot. It was very difficult. How I already saw in my presentation, we had only one case of West Nile virus with COVID-19 too, after the West Nile virus. This is the reason, because our hospital is from March 2020. It is a COVID-19 hospital, only COVID-19 patients. We had more than 10,000 COVID-19 patients in the last year hospitalized in our hospital. And but from the our CDC, we don't have results about West Nile virus in 2020. They are overwhelmed about from COVID-19 too, and we don't have data. I don't know, because all infectious disease hospitals was transformed in the COVID-19 hospitals. And it's very difficult, because I don't know how much this patient was tested for COVID, for West Nile virus or other viruses in this year. And probably the same situation in 2021, because we still have more than 400 patients. More than 400 patients hospitalized in the hospital this moment.
Yeah. Yeah, it's so we hear all this delayed care, delayed surveillance, and I think this is also a clear example. Erwin,
Yes, the same here. Very much delayed. So the last year of collection was 2019. So we received the samples very late, very much delayed. Also the testing was delayed. So yeah, the testing was done in the end of 2020 instead of the end of 2019, what you would expect. So yeah, so for 2020, almost everything was SARS-CoV-2.
I remember reagent shortages also affecting the bird surveillance, for instance, in different parts of Europe.
Yep, some fabrics produce only mouth masks at the moment, and other products are on hold or delayed. So that's also an issue there. Yes.
I don't know if we have kits for West Nile virus or for other diseases in our hospital.
Yes.
Because
so Louise, what about you?
Expired after 1 year.
Yeah. No, I think it's the same. Everything is, we've been all busy responding to the COVID pandemic and supporting sites with clinical research response to COVID-19, really. So I think, but now we've got the now we got the serology and the PCR results and the data. So we'll accelerate the final analysis to be prepared for the summer season. For the next Arbovirus season, I think that's the plan now. But yeah, it's all been delayed.
So but maybe then the follow-up question is, thinking in the future, thinking about Europe's preparedness, what would need to change if, you know, a future, so this is essentially a question about how much, room do you need to be able to cope with emerging disease outbreaks in a clinical setting, in a laboratory setting, in a research setting? Can we take the same route, Cornelio?
Okay. I don't think that, I don't know. It is very difficult for us. What I observed is it is very important the human resource in to be prepared for something like this, because now we are prepared because we have months in our back with COVID-19. But it is at the start was difficult, because some of us are prepared because this is our business. We had Ebola, we had other interesting situations, but not for all. The others are in their world, not in our own world. And the human resource, I think, is the most important.
So do you say, so right now this study was focused on arbovirus. Should we get a generic protocol to include infectious disease patients?
Yes, can be an idea. Luis?
Yeah, no, I think that's really interesting, the human resources. I was thinking about that when I looked at the study, putting together a presentation. It's really about the people behind all this data and figures. It's a big networks and collaborations, and it took time to establish those networks in the beginning. We spent a lot of time, but once we built the connection, it's been amazing. And each connection, you know, brings on more people on board. And like you said, Cornelia, we now are trained and we understand what we need to do in terms of implement clinical research responses. But like you said, in the sites, when you have a bigger pandemic, you might need to, it's interesting, take on training other people in your sites and in general to step up and contribute to have a, what do you call it, an extra capacity. But I think that's the human resources and keeping, and the networks where we can share these resources between us and share resources and tools, and having pre-prepared protocols, I think is really helpful. But also, like Cornelia said, making sure people are trained in using them and understand how to manage it when you have an infectious disease outbreak, and what needs doing is an important aspect, I think.
I guess a lot of experience to take forward.
Yeah.
So go ahead.
No, I just want to stress the networks we built up now. We need to sustain them. I think that's the key. Sustain our networks. So it's behind the scenes of politics. We can move mountains together, really, and do what needs doing sometimes if we just have the right, you know.
Well, maybe know each other, and maybe this is more easily to collaborate in the future.
Yeah,
when already the base are made.
Yeah.
Maybe also the question for Erwin. So you've been working on this multiplex serology for many years now. It's challenging. What would be your recommendations taking forward?
In common, you mean, or if there is a new outbreak like this?
Well, in terms of getting prepared for, you know, more frequent outbreaks, or the ability to detect arboviruses wherever they pop up.
Yeah, I think having such a network where a lot of different groups work together and different expertise, and having platforms like the protein microarray sequencing and detection assays. So, well, I'm mainly looking for a lab effort, of course. Is that if you can work together and make such tests available as soon as possible, and also validate them together, to know that at least what you use is of good sensitivity and specificity. That will be very important, of course. Yeah, what to do for expecting the unknown. Yeah, it's really difficult to be prepared for everything. That's also what we've seen in this project. It was called prepared, but sometimes we were not that prepared for everything.
If we are prepared for everything, no fun is in this.
That's true.
Okay, so yes, maybe those are very wise closing remarks, Corneliu, because that's true. I think that there is always new things to learn, and I want to thank you for the presentations. I do think there is many lessons to learn from this and to take forward for the next phase of preparedness for Europe. Thank you very much.
Thank
you
you.
too.
Thank you.
Bye.
Thank you, everyone.
And bye.
Bye.